I want to start by introducing myself. For those of you who don't know, I'm TJ Alvers. I'm a health policy coordinator at SIU School of Medicine's Department of Population Science and Policy. But for today's event, I will be a co-MC along with Vistrit Chaudhary. And we're very excited to welcome all of you here in person at the Memorial Learning Center, and then those of you joining virtually via WebEx. We also want to thank our sponsors, the Department of Population Science and Policy at SIU School of Medicine, the SIU School of Law, and Southern Illinois Healthcare. We got a great slate of speakers today that we're very eager to hear speak. They have a lot of interesting things to say and have powerful voices to get things done in the state of Illinois. We built in a Q&A portion into each session, both speakers and panelists. And for those of you in person, please raise your hand and Vistrit or myself will come to you with a microphone. And please only speak your question once you get the microphone, because that allows those attending virtually to be able to hear the question. And then those of you online, we have somebody monitoring the chat on WebEx, so we'll be able to read your question and pass it along to the speaker or panelist. And those are all the housekeeping items I have, so let's jump right into it with our welcome so that we stay on schedule today. We have 3 speakers, and I'll introduce each of them here at the front and then have them follow one another. Leading us off will be Dr. Jerry Kruse, who's the Dean and Provost of SIU School of Medicine and the CEO of SIU Healthcare. Following him will be Dr. Wiley Jenkins, who's a research professor and the interim chair at Southern Illinois University School of Medicine's Department of Population Science and Policy. And finally, Woody Thorne, who's the Vice President of Community Affairs and the Chief Development Officer for Southern Illinois Healthcare, a nonprofit for integrated healthcare systems in Southern Illinois. Thank you.
Thanks, TJ. I am Jerry Kruse, the Dean and Provost of SIU School of Medicine. On behalf of the School of Medicine, welcome to all of you to the Memorial Learning Center, really a great facility. That is a sign of the great partnership that we have with Memorial Health throughout central Illinois. And we see all of you as our partners as well as we innovate Illinois. I like the title for this conference because that's what we're doing now. We've had some really great success in identifying the issues and the problems in the rural areas in Illinois with our series of rural health summits. And so this now is the time to get to the solutions and get to the innovations. Okay, so I'm from a rural area. The slide you see up there shows that I'm from Salisbury, Missouri, a town of 1,700 people, 100 miles east of Kansas City in north central Missouri. There's a few scenes from Salisbury, the Brummel House, Wright Service Station, Lyric Theater, Emmanuel Lutheran Church. Down in the lower right-hand corner, that's not me. I was not born in 1930, as a matter of fact. But that is my dad, and both my mom and dad grew up on very small farms in the midst of the Depression. Very, very tough times in the United States. Now, there's my mom. She was very, very fortunate in 1936 when she graduated from high school in that small rural town to be taken under the wing of the family doctor in town, Dr. George W. Hawkins, who you see in this slide as well. He trained her to be his office staff, his entire office staff, biller, coder, collector, counselor, nurse, the whole thing. You know, the two of them did the healthcare in Salisbury for the next 17 years together. And it was quite a time. That baby is not me, but you'll see me in just a few minutes. I was born in Woodland Hospital in Moberly, Missouri. That's a photo of it. And I was delivered by Dr. Hawkins. He actually did his hospital work 21 miles away from Salisbury. And so there I am just after I was born. I was in an incubator for a period of time. I don't know what exactly was wrong with me, but Dr. Hawkins delivered me, made a home visit there. My mom's kneeling beside the crib. And standing behind Dr. Hawkins is his wife, Eula Bell. Now, George and Eula Bell like to take holiday in St. Louis, and they'd take the train from the depot in Salisbury to St. Louis. when he left, he'd give his keys to the Model T Ford to my mom, who would drive around with a black bag with injectables. 3 of them were in the black bag. Penicillin to combat infection, cortisone to combat inflammation, and stelazine. Anybody know stelazine? Long-acting antipsychotic medication. It was pretty good public health at that time. Anyway, one last thing. Mom liked to write on photos. I guess you can't see it there where she wrote Jerry preaching. She was sure I would be a minister. But if you take a close look, my first lecture there was about bufferin, the first pharmacology lecture. So anyway, why did I bring this stuff up today? I'm going to go back here a couple slides. It's because I think this is relevant to the solutions and the issues that we're going to be talking about today. To me, this brings up 2 fundamental issues related to rural health care. I think you can probably see what kind of comprehensive care was given in that office. It was completely comprehensive. It was completely accessible. I think most of us know that as times have changed with the advent of urgent care and the advent of hospitalists and the advent of full-time emergency medicine physicians, the level of comprehensiveness given by the primary care physicians, the other clinicians, and the entire system has waned. We have far fewer usual sources of comprehensive longitudinal care, something that's absolutely needed for our healthcare system if it's going to be most efficient, effective, and equitable, and differentially affects rural populations. Think about this for a minute. It's hard to get a generalist of any kind. The number of general surgeons is waning. The number of general neurologists is waning. The number of general urologists is waning, and you can go down the list. So that's one, as we build solutions for the rural populations, we have to come to some kind of solution for the ebbing of generalism in general. Now, the other thing is this. So my mom died in 2014, near Christmas, actually. And just, I think it was the day, December 23rd, we had her funeral. Before the funeral, we had a little visitation and a wake in the church, and people would pass by. It had been fully 61 years since she had spent her last day in Dr. Hawkins' office. But I was astounded that day by the number of people who came in and related stories about the care that they got in the office 61 or more years ago as children, for their parents, for their grandparents, and just the level of care that they described and the level of trust in the system that they had. So that's the second point here as we develop solutions. We've learned at the SIU School of Medicine through our hotspotting program, through our community assessment, community development program, through the development of our community health workers, that one of the significant issues to solving problems in communities is understanding the level of mistrust that is there and working on that mistrust in the proper way. Building trust by identifying community leaders, people on the ground, and working together for them to develop the solutions that are needed as we move forward. So I would just say, looking through the set of speakers and the set of the program that you have today, I would just ask that you remember as you're working on these solutions, the issues related to generalism in the delivery of healthcare and the level of trust in the community and how that needs to be built back up are 2 very important things. So thank you very much. It's a pleasure to see all you here today, and I look forward to working together with you as solutions are developed for rural Illinois and rural America. And now, Dr. Wiley Jenkins.
Thank you, Dr. Kruse. Excellent introduction, and I do really appreciate the influence of the influence of healthcare and private and small rural communities as well. And so my name is Wiley Jenkins, as described, and I'm interim chair of the Department of Population Science and Policy. I've assumed this role due to the departure of Dr. Vohra, who has been asked to lead the Illinois Department of Public Health, and he'll be speaking with us later. And so it is some degree of both gratitude for the opportunity, but also humbleness that I approach this role because it encompasses so much more than I'm used to. And so I am a researcher by trade. I do not provide care. I am not a clinician, but I do really try to understand and look at how do things work. And that is, I think, what for me is especially pertinent for today and special about the work we do is that so often many interventions, many policies, many programs are developed in much more metropolitan and urban areas. And very honestly, you get an economy of scale frequently with hundreds of thousands of people. You get to see effects, you get to see how things work, how people may react, how policies may have immediate impact. But so often people assume that that will work equally well in smaller communities. And we all know that that just frequently isn't the case. But rural communities are not just deficit driven. They have strengths, they have opportunities and resources, but those really need to be teased out. They need to be identified and they need to be leveraged and engaged in a collaborative sense. And that's a lot of the work we try to do with our research, with our policy work. And I really look forward to hearing about how policies can impact rural areas from some of the speakers we have today, some of how the healthcare advantages and some of how the interventions that are devised can make its impact. I really look forward to hearing from our speakers. So as I said, we are the Department of Population Science and Policy, and really central to our mission is really exploring, trying to understand some of the challenges and opportunities faced by rural residents, especially in central and southern Illinois. I mean, that is near and dear to our heart as SIU School of Medicine. Many of us are from this area. I spent a number of years in my childhood in both Crescent City, Illinois, and Clifton, Illinois. Anybody may know where they are? Somewhere near Kankakee. So I have some idea. On the other hand, I've also was born in Albany, New York, and I went to high school in Hammond, Indiana, up near the Chicago Endless suburb. And so I really do have that mixture of experiences of knowing what it's like driving from one town to another, not even knowing you've left, except there might be a little sign somewhere, versus also some of the small rural areas and really the neat strengths and opportunities they have. So today's event is really a combination of two existing events, both the Illinois Rural Health Summit and the Southern Illinois Healthcare, Southern Illinois University Health Policy Institute. The Rural Health Summit traditionally has been focusing on addressing health disparities faced by rural communities, and the Southern Illinois Healthcare SIU Health Policy Institute since 1999 has focused on the impact of health policy on Illinois communities for a long time. And so today's event is really a combination of those two events, the Innovating Illinois Rural Health Summit. And so this is provided by the Southern Illinois University Population Science and Policy Department, the Southern Illinois University School of Law, Southern Illinois Healthcare, and we'll be hearing from Woody Thorne in a little bit. Well, very briefly, as soon as I'm done here, to describe some of the work that SIH has done, and we are grateful to our partners for helping us sponsor this event, to helping shape the agenda, and helping to invite the speakers and bring together an excellent program. So frequently, rural needs are often overshadowed. And we really seek to make a difference in that. We seek to understand what are the differences, not only where things may not work as well, but what are the opportunities we seek to leverage those. And so we know rural communities face rural specific needs and policies to make real sustainable change. Our agenda and speakers will highlight and share the programs that are working, discuss potential solutions for common rural challenges. Our agenda today covers rural health broadly, children and maternal health, the opioid and drug crisis as that's been evolving. And so I really look forward personally to hearing from our speakers, from our program about new and innovative things that are done. And I hope that you find this time very well spent. You have opportunity to collaborate, to network, to learn new things. And so I do appreciate you being able to be here today, both in person and virtually, and hope that this exceeds your expectations for value. And with that, I'd like to introduce Woody Thorne from Southern Illinois Healthcare. Thank you so much.
So thank you very much, Wiley. Thank you very much, Dr. Kruse, for showing us your slides. I have about 15 slides with my grandkids. I'd love to be able to show you, but I'm going to be really, really brief because I'm very interested in hearing from our partner at the Department of Public Health. And so to be very brief, as was referenced, my name is Woody Thorne. I'm very privileged to serve in the role of the the Vice President of Community Affairs and the Chief Development Officer for Southern Illinois Healthcare. And SIH has been a partner in this program since its inception. And I'd like to just welcome all of you, along with my colleagues, Dr. Kruse and Dr. Jenkins. I'd like to also thank the team from the Population Science and Policy Department for their leadership in rural Illinois and for their work in coordinating this event. As many of you know, rural Illinoisans often face many challenges in accessing healthcare. Healthcare providers right now are facing significant barriers to advancing the healthcare and the health of our patients and the health that they deserve based on growing financial pressures. The socioeconomic divide is producing many social determinants of health that we as in the healthcare space are finding as ways that we can partner across the community, across various sectors to meet our patients' needs. As a leading provider of care in the southernmost Illinois, SIH is working across the community through our Community Benefits Department and through this ongoing work of our physicians, our clinicians. We're working to meet the needs of our patients and those we serve in the region. Through this work, we're trying to further the mission of our organization of improving the health and well-being of all the people in the communities we serve. And it's my pleasure, again, to welcome you to this day's event. So thank you very much for being here.
Good morning. I'm Visrat Chaudhary, and I'm a health policy coordinator with the Department of Population Science and Policy. And it is my great pleasure to introduce my former boss and the current director of the Illinois Department of Public Health, Dr. Samir Vohra. Dr. Samir Vohra was appointed as the director of the Illinois Department of Public Health effective August 1st by Governor J.B. Pritzker. Dr. Vohra is a general pediatrician who also holds degrees in law and public policy. He is a cross-disciplinary leader in state and national health policy formulation, and his recent focus has been on improving health outcomes in central and southern Illinois. Immediately prior to his appointment, Dr. Vohra was the founding chair of the Department of Population Science and Policy at SIU Medicine. He has received numerous honors, including a United States Fulbright Scholarship, and most recently being named a Presidential Leadership Scholar, chosen by the George W. Bush Presidential Center, the Clinton Presidential Center, the George and Barbara Bush Foundation, and the LBJ Foundation. Please put your hands together for Dr. Vohra.
Well, thank you, Visrat, for that introduction. Thank you to Dr. Kruse, Dr. Jenkins, and Woody Thorne for the invitation. It feels a little bit odd coming here, not as the founding chair of the Department of Population Science and Policy, but instead the director of the Illinois Department of Public Health. I have now had that job for almost 3 months, and I would say that the amount of learning, the amount of networks built, but also seeing the incredible public servants in our agency. Kristen Nolan, who I will kind of talk about a little bit more, is with us, who heads our Center for Rural Health. Director Eagleson, who you'll hear from shortly, as well as the Director of the Healthcare and Family Services, but also the incredible partners that we have in every one of our 102 communities. Often, though, those stories of our rural residents aren't discussed as much, aren't featured in the same ways that many of our urban colleagues do. And part of a unique conference or summit like this is to really shine the light on those stories. Think about the incredible work that's happening, but also how we can build into the future. And so I'm told I can only go between these two black lines. And so I want to welcome all those that are attending virtually as well. And so great to have the opportunity to have a conference, not just to see all of you in person, but have the technology now that we use much more based on the COVID-19 pandemic to be able to reach audiences that sometimes, because of our own kind of transportation challenges, they're not able to come. So over the next hour, I hope to kind of do a few things. First, to kind of describe just the challenges that we see in our rural communities. Much of this is data that we've pulled from our various kind of IDPH sources, but then also sort of use that as a baseline, because I don't want the story of our rural communities to be one about disadvantage. But we do see that often that is the case, right? When we talk about rural, we talk about the challenges that we see in rural communities. We often don't talk about the innovations. And part of this is it's both challenges and opportunities. Things that are happening in government, things that are happening in our everyday communities that government can highlight and support. And then ultimately, what are opportunities into the future? So for many years, and even when the Department of Population Science and Policy first had the Rural Health Summit, that was back in 2018. And part of the goal during that summit was trying to find better and more innovative ways that academia in a place like Southern Illinois University could interact with government. Through Dr. Kruse's leadership and others, SIU has broadened so many of those partnerships. Now, as I sit on the other end, then the question is, how can government sort of reach out and learn from our partnership colleagues, learn from that innovation, and determine ways that we can find those solutions? So let me start. This is Warren, Illinois, and it could have been Hillsborough, Illinois. It could have been Centralia, Illinois. Communities with often these small town squares in which a community comes together to bring about change. And Dr. Kruse shared his story of growing up in a rural area. I did not grow up in a rural area. I grew up, born in the city of Chicago, on the western side of the city, moved into my youth into the suburbs of Chicago, and then got an opportunity to, after my undergraduate studies, to come to Southern Illinois University to do a medicine and law dual degree program. And so spending your life in Chicago, Champaign is Southern Illinois. And going all the way down to Carbondale and going to that first year of law school, let's say that was a little bit of culture shock for me. To be able to see all of these kind of open areas, to sort of find out that people in the rest of Illinois, everybody wasn't a Cubs fan. But also to understand that like so many people didn't view the world the way that I viewed it in the city of Chicago. And that takes an adjustment, right? And it takes an adjustment right now in our own society where we are often placed in our bubbles of what we feel comfortable about, how we seek the opinions of those who think like us. And then those opinions get amplified through social media, through other forums. And the idea of, well, all politics is local and community, that looks very different now in 2022. But what I found through those moments in Carbondale was that many of the people that might not have shared my political viewpoints or might not have grown up in the same neighborhoods as me. Yeah, we might have argued about Cubs versus Cardinals, but those became some of the best friends and still some of the best friends that I've ever had. The people that would travel across the state and across the country to help in times of need, people who both similarly, despite our different viewpoints, wanted our children to go to school and get the best outcomes. They wanted to have the safest way to raise a family, to find the right kind of health care to make sure that they could grow and age in place. And those things are unifiers. And many would argue, and I think it would be hard to ignore, that the last 2.5 years, where we all faced and continue to face in a little bit of a different form now, a once-in-a-century pandemic, that health wasn't a unifier. That health all fractured many components of society. But I don't think that's true. And I'm not ready to believe that that's true. And part of it is because even though I would say this often as the department chair of population science and policy, I'm not the face of rural. But, you know, I went and see Rex Brown in the audience. You go to Hillsborough, Illinois, and you become welcome not because of who you are or where you came from, but because you share the same goals and you sit and you listen. You listen to people, you listen to people's stories. And part of that in a Innovating Illinois Rural Health Summit, where we take ideas from the Rural Health Summit and through an SIU scholarship, the Health Policy Institute, how can you create the platforms for greater action? So I'm going to start and with just sort of providing you with data and information around what we see in kind of our rural communities. And so this, for those that are familiar with population science and policy and the Rural Health Summit's work, which was a partnership between the UIC School of Public Health, the SIU Medicine Center for Rural Health and Social Service Development, the SIU Paul Simon Public Policy Institute, and SIU Population Science and Policy. They released a series of briefs throughout the COVID-19 pandemic that talked about the challenges that rural Illinois faces. And part of that was these 5 Ds. That rural Illinois, based on sort of leading health indicators, often are at a disadvantage. They're disadvantaged in their morbidity and mortality. They're often at a disadvantage in terms of their rates of certain illnesses. They're also often in disadvantage in terms of income status, social and structural determinants of health that we know often guide our health outcomes. Part of this is because there are a series of deserts. We just discussed already the healthcare service deserts that we have, and you'll see some slides about those things later. But the other parts of our deserts are many of the other things that you need to be healthy. We have deserts of early childhood services. There are deserts in rural communities in terms of grocery stores and often the food insecurity that it's placed. And part of that is then magnified by disconnection. We can sit here and we have the opportunity to have the ability to live stream this across various audiences, but the COVID-19 pandemic, when so much of society moved to a virtual platform, from learning to social interactions to healthcare, that those things were often limited by many of the challenges around disconnection of technology. But that disconnection was also the way that many of our programs and services talk to each other. That we sit and now have the great pleasure to lead an organization of nearly 1,200 individuals. But even within that organization, there are separations between our programs and functions. Even then, there are other agency partners that are doing incredible work in rural areas, from the Illinois State Board of Education to Healthcare and Family Services to Human Services to Transportation. And our own sort of separate functions then meet with their separate functions. And how do we connect those things together? Because I, as a citizen, and I, as a resident, or many of the most vulnerable that we serve, well, they're not looking at it within those different contours of society. They're looking at it by themselves, of their family, And those things need to be placed together. So what does that create? That creates that fourth D, disparities. Disparities in health inequities in ways that we see ultimate health outcomes. And part of that then gets magnified by just the lack of developmental opportunities. I was just in Chicago yesterday. It was and as an undergraduate at Northwestern, it was my ability to have a Northwestern day. So went to the undergraduate campus, then got to visit the incredible facilities at Lurie Children's Hospital. And we have Colleen Cacchetti, who you'll hear from later as well in the back, and Amanda Walsh as well, and sort of that work sitting, and you can see, right, the wealth and the development of those places in the city of Chicago. But when you go to places like Egyptian County, right on that Saline, Egyptian Health Department with Saline, White County, and you see just the differences. And part of that is because there aren't the same economic opportunities. Philanthropy looks really different. And often what sort of sits as the piece that can do the most development is often our healthcare facilities. But then there are times where even that's in question. And we know now, and as all of you have seen, the staffing challenges that we see across our different healthcare facilities, the ability even of so many that we're fortunate, fortunate that at a moment that we still sit in a relatively sort of calm period in COVID-19, still preparing for that surge, but we're also seeing bed challenges around kids sick with RSV and other viral illnesses. We see the flu already starting, and the lack of development opportunities to bolster that, even that much more magnified in our rural communities. So here just sort of a couple slides about when we think of rural, just in general, that our rural residents tend to be older than our urban residents. And so on that top line, you see sort of non-metropolitan communities. Below that, you see metropolitan communities. And these graphs will be similar for the rest of the sides, right? Older base population. Then that population also tends to be at times having more difficult kind of financial opportunities. And so this is poverty in metro and non-metro communities. And as you see, just that idea of, well, where does it sit that we are facing these challenges in both sectors, but that much more around rural communities? Then we get to the deserts, right? Maternity care. And you could take maternity care, and we'll see in some of the other slides, but you can put mental health care. You can put specialty service care. And to Dr. Kruse's points earlier, that we have these deserts in specialty care without the lack of generalists also coming on board. And what you see is just a vast deserts. And this slide gives an introduction of just the different levels of obstetric care. But that since 2016, we have had 22 OB units close. We've had 5 facilities close in general, only 3 of those facilities open. And although that is in some ways more prominent in the city of Chicago, there are other places in the city of Chicago to replace that. While when you lose an OB facility in central Illinois, and when we go down the state, there weren't even many to begin with in the deepest aspects of southern Illinois. So then who gets affected? The truth is everybody, but often in our communities, and when we talk about the inequities, those that are the most vulnerable get affected the most. Often that conversation is around communities of color in the bigger metropolitan areas here in Springfield and the city of Chicago and places like Rockford and Peoria. But it's also similarly true around rural communities, that they get predominantly more affected, and you see just the deep challenges that occur with patients that now have to travel often huge distances without the transportation opportunities to even get there. And so what does that lead to? Ultimately leads to poorer outcomes or more economic disadvantage for communities and individuals to go to the places in which they need care. And this is something that often is a place where we need to think about, well, how can we create the right interactions and supports to make it happen, right? Make these changes happen in an environment where we can get the right kind of statewide support. The next is just the idea of, well, where do we have health professional shortage areas? And when we measure those both from a state perspective and a federal perspective, often health professional shortage areas are thought through in terms of primary care delivery, in terms of dental health, and in terms of mental health. And I want to sort of share some maps to show where those areas reside here in Illinois. So here it is, a federally designated health professional shortage area in primary care. And as we see, the green is a geographic health professional shortage area. The pink is a low-income Medicaid health professional shortage area. And I think part of the thing that we take these slides, that's a lot of the state of Illinois. And that is mostly our rural and small city communities. When we take that map and we see all the pink and green, when we go around to thinking about mental health, it's primarily a desert everywhere. And we know the healthcare challenges that we see, but often, and only very recently, do we have had more conversation in every sector of how critical mental health is. And how critical mental health is before the COVID-19 pandemic and then magnified during the COVID-19 pandemic. That thus the ability for residents to access mental health services is an incredibly deep and really critical challenge. And then we see something similar too around dental health, right? And I think part of this is that often when we have separated these functions of here's your primary health care, here's your mental health care, and then here's your dental health, 3 places for 3 vulnerable families often to go. And one of the great innovations that we see it at places like SIU, we see it growing throughout the state in places like SIH. Well, how do we integrate the delivery of healthcare around primary care, dental health, and mental health care services? And so, more things to just show just the challenges around rural communities versus urban communities. This is kind of the mortality gap based on the leading causes of death throughout Illinois. And we see in most of these categories sort of very similar around cerebrovascular disease, strokes. But when we get into accidental injuries, when we get into COVID-19, when we get into cancer, when we get into heart disease, when we get into all causes, there is an increased mortality gap in rural communities versus those in urban communities. And that list only gets bigger. Here's chronic obstructive pulmonary disease, asthma, cardiovascular disease, diabetes, depressive disorder, arthritis, and any other sort of chronic condition. And these are the realities of those 5Ds, right? These are the disparities that we see all the time in our rural communities. And let's kind of dive deeper. So pregnancy-related mortality ratios, right? Birthing persons living in rural counties have the highest rate of pregnancy-related mortalities. Why? Well, we just sort of went through that, right? We saw the birthing deserts that exist there. And then we also know just a lot of this is also driven by how all of these things relate to each other. The birthing challenges can often be linked to, well, how is your mental health? How is your ability to access a primary care clinician? Because it's not just the aspect of going to a birthing hospital during delivery, it's all the things that come before that. And to build the right kinds of systems, how do we think about these things holistically? You'll hear about some of the stuff around healthcare transformation later from Director Eagleson, but I think part of this is just sort of setting the foundation that is needed in our health and healthcare systems, right? Not to say that they're separate, that public health and healthcare need to be connected. Because if we don't deal with those issues before they manifest, and then we get to places around having deserts of services, that's when we see those disparities in action, and we need to think about developing all of those things to build the right health systems. So what are we doing in the Illinois Department of Public Health to think about rural issues? And part of the challenge of any kind of statewide entity is that there's often a focus around our services, thinking through the lens of what we can do to help the most people in our state. And when you think and work in that frame, it's only logical that you're thinking about areas, all of them, but the data gets driven around those highest population centers. And that in some ways makes sense, right? If your metric is always sort of geared around, well, how do we think about driving the change across the entire state in numbers, right? But part of that has to be sort of aligned with that each of our communities are different. They have their different assets. They have their different challenges. And building a web of all of those communities together around their individual both strengths and differences. And part of that was the Illinois Department of Health's acknowledgement that we needed a center to drive and understand rural issues, but also be the place in which federal funding opportunities could be passed along through our state health department into our rural communities. So as I mentioned, we're very fortunate to be led in our Center for Rural Health by Kristen Nolan. Previously, many of you might have worked with Julie Casper, who was in that role for many, many years and was a great public health servant. And part of that role in the Center for Rural Health was an acknowledgement that in 1989 that we needed a place within the Department of Public Health to improve access to primary health care in rural and underserved areas of Illinois and to encourage community involvement in health issues. and also serve as an information clearinghouse on rural health issues in Illinois. Much of this was based on a recommendation of the governor's Rural Health Task Force at that time, and linkages now with the governor's Rural Affairs Council that's chaired by Lieutenant Governor Juliana Stratton. So what does the Center for Rural Health do? So first, part of it is we are able to think through some of those data points that you saw. We determine the eligibility for several government programs on those shortage designations. It allows us to know where we can provide those resources best based on those federal guidelines. And those include geographic areas, population groups, or healthcare facilities that have been designated by the Health Resources Service Administration, HRSA, as having a shortage of health professionals. This allows us also to best use the programs and the federal funding that we get to be aligned into those areas most in need. And so part of some of the different programs that are housed in our Center for Rural Health include, first, the primary care office, which conducts needs assessments, determines what areas are eligible for designations, submits designation applications to HRSA, and HRSA reviews the applications and designates the areas or populations or facilities based on these eligibility criteria. But it also sort of thinks through a whole host of other programs. So the State Office of Rural Health requires the center to serve as the state's contact for the clearinghouse of rural issues. And it provides technical assistance to organizations and residents interested in rural issues. We mentioned the primary care office. We also have the Medicare Hospital Flexibility, FLEX, which really works with our 51 critical access hospitals, our Illinois Critical Access Hospital Network led by Pat Scow, who you'll also hear from later today, and thinking through quality improvement reporting, performance improvements, benchmarking, and it really contracts out with ICANN, the Illinois Critical Access Hospital Network, to really think through who and what are the best partners to kind of make action happen. Fourth is the Rural Hospital Improvement Program, acronym SHIP, and it funds and assists rural hospitals throughout Illinois with special projects. This year, an additional award was made to SHIP hospitals based on some of our COVID funding. These ideas and things that we think about here are value-based purchasing, accountable care organizations, shared savings, payment bundling, prospective payment systems, and IDPH subcontracts with ICANN to administer this program. Fifth is our state loan repayment program, and it is used currently to repay educational loans for primary care physicians, dentists, psychiatrists, physician assistants, nurse practitioners, and certified nurse midwives who are U.S. citizens or nationals agree to serve in designated health professional shortage areas. And recent legislation allowed us to kind of expand this access in this program, and currently working to finalize the rules to bring that into action. And part of those state programs that allow us to think about workforce include the Nursing Education Scholarship Program, the J-1 Visa Waiver Program, the Pediatric Scholarship Program, and the Underserved Healthcare Provider Workforce Loan Repayment Program. And so part of this is that these programs sort of funnel through the Center for Rural Health. They allow us to designate the areas. But part of what we seek from all of you, one is how we can do this work better. And then two, how can we create the right linkages for growing conversations to find innovative ways that we can both adapt and expand our work. So we talked about the challenges, we talked about our IDPH Center for Rural Health and the programs that we do. And there's a lot there. And part of going into the detail of all of those programs, we want you to find us at IDPH. If you knew about those programs, we want you to tell us, well, what's working, what can we do better? If you haven't heard about those programs, well, that's what they're here for. And I think partly one of the other things that is very clear just from my 3 months into the job is that we have incredible state-based programs. But sometimes just because of the complexity of those and how it relates back to a regular citizen or community member, it's more on us to use platforms like this to tell you about those programs and tell you to contact us to learn more. Because that's really critical, because often our programs just aren't being utilized in the ways that they can be. And that's money and opportunity, and one of those 5D development opportunities that we can provide to all of you in your communities to make an impact. But despite the good programs that we do, I think there's always areas for improvement. And one of the things, moving from somebody who used to be in a place where I was always trying to figure out ways to push government to do better. Now in government, I need to accept all of that as well, right? To all of you to tell us what we can do better. And it is our job to sit and work within our constraints to navigate systems. I think part of that is that we are very fortunate right now to have a governor in Governor Pritzker who wants to improve all of these functions in government and is constantly working around all of our agencies. So one, we talk to each other, and in all the correspondence, phone calls and emails that Director Eagleson and I have had this week, and then meeting today, but also thinking that it's not just about health and even human services, that we need to talk across all different sectors so that when you tell us something, we don't tell you, well, that's not our agency that does it. But provide that link to make sure that government is connected along the services that our residents need. So many things around opportunities, but I'm going to talk about 3 things, and 3 things that I hope we can build a bridge with all of you to continue to talk about, to continue to improve, and very forthrightly ask for your help, both in the audience and virtually, around making these opportunities realities. I think one of the things it starts in these opportunities that we spoke a lot about the challenges, but in my travels across rural communities all across the state, but especially in central and southern Illinois, despite the challenges, the greatest asset is the closeness of these communities. Dr. Kruse shared the incredible story of his mother and how much those connections run strong and run deep and extend for years and generations. Sometimes, and I've heard that in our rural communities, a little too close, right? That everybody knows everybody's business. But at the same time, it allows an opportunity for incredible action. Now, if there's an issue in Chicago, to get the hospital CEOs, the mayor, the superintendent of the Chicago Public Schools together, maybe that's 3-4 months of scheduling to even think about making that happen. But in a rural community, and I've experienced this and through the help of Rex Brown and others, well, we can get all those people together in a day, in the evening, to be on a call to kind of talk about those issues, right? And that social rootedness, that connection to each other, it's hard to put a measurement on that. And I'm showing you data here. There's no kind of blood test we could run for that. There's no sort of kind of concrete measurement. But man, is that a powerful tool. And a powerful tool that can be combined with the first opportunity of sharing more rural Illinois stories. So my predecessor, and thanks to Dr. Ezike for all of her leadership during the COVID-19 pandemic. And part of that meant that the public health director, along with the governor, stood in front of the media every day, often during the beginning of the pandemic, to explain to the public what the COVID-19 challenges are, what the state was doing. During my introductory press conference, I got asked that question. Well, Dr. Vohra, will we see you the same way that we saw your predecessor? And my response was, well, I hope not. Because although I am here whenever the governor calls or whenever the media needs me to explain a story, it often means that there is some deep, deep challenge that needs that kind of level of attention. But what I didn't say there, but is also 100% true and a deep belief of mine, is that as much as I can and already have been often the spokesperson for this administration around public health issues, the best stories are those from the individuals in our communities that are doing the innovative work every day, that are showing the challenges to all of you that they're facing, and then showing you also the innovations that are happening. And it can be, and it will be, and it's already starting to be, that IDPH's platform is to share the health stories of our residents. And yes, we're going to share many stories from neighborhoods across the city of Chicago and our smaller urban areas. But we also need to hear the stories of the rural communities. We want to hear about that social connection. We want to hear how the hospital and healthcare is taking those challenging times and turning the ideas into action. It's been about a month, but I got to visit the Regional Healthcare and Community Coalition in Southern Illinois and got to see Vice President Thorne there, and how innovative that location is, housed in an airport hangar, the hub around how supplies and coordination can happen in an emergency. I was floored. And that was after traveling across Southern Illinois countless times, in the last 7+ years, but not knowing that that infrastructure existed the way it did until I became IDPH director. The innovations that are happening in places like Centralia, Illinois, where they're thinking through with leadership around how to address adverse childhood experiences and trauma, and some of that throughout the time with leadership from juvenile justice and judges and community members, all thinking about how health relates to children. These are stories. These are people that are dedicating their talent, their work around making an incredible difference. And that is a platform that should be heard by every member of the state through our own avenues, but also allowing our avenues where you can tell your own stories, because part of it is that when we feel all connected to these stories is when we can find the action around these greater developmental opportunities. Opportunity 2, bridging public health and healthcare delivery. So part of a innovative Illinois Rural Health Summit like this is the idea that, well, in population health, how has the healthcare system thought about the health of the populations that it serves, right? But often there is this great separation between, well, what does local public health do, local health departments, and how does that match what happens in the healthcare delivery space? And that is often a cause of tension. It leads to, well, tell me whose responsibilities are where. And then trying to get a sense of, well, who is that chief community health strategist? Trying to determine how all of these pieces connect together. We have examples of incredible relationships between healthcare and public health. Southern Illinois Healthcare is one great example of that, and sort of trying to create and push avenues where Southern Illinois Healthcare can work with the Southern 7 health departments. We see that right here in Springfield, although we wouldn't necessarily call it rural, but great connections between the local health department and the hospitals and even SIU School of Medicine. But more work needs to be done there. And part of it is just even the silos in terms of funding, in terms of the way that we talk about these issues. But COVID changed that too, right? That we couldn't live in a separate function in which, well, public health had this lane and healthcare delivery had this lane. They needed to be thinking in coordination. They needed to be figuring out ways that healthcare service delivery was thinking through public health and healthcare challenges. And how do we put that in action, right? And how do we sort of combine those conversations? And partly like this is happening in real time as both, leadership in healthcare and family services and the Illinois Department of Public Health, had a conversation with the chief medical officers across the state of Illinois just last week as we strategized on areas to address and think through both the communication to prevent illness, but then what was needed in terms of providing and thinking through the healthcare delivery resources. And some of that is intentionality. And I know in many of the conversations that I've had with local health departments, that intentionality may need to happen from the local health department to reach out, to sort of think through the challenge. And we want to model that on the state level. But some of it is also just this idea of connecting some of the structures that both healthcare delivery does and the Illinois Department of Health does around the data, the community assessments we do, and the implementation plans. So I have had the chance to review the Illinois Project for Local Assessment of Needs that is sent to our Illinois Department of Health Office of Policy Planning and Statistics. I get to sign a great certificate that says you, local health department, did this community assessment as part of your I-plan and sort of came through with implementation ideas. But often what we find is many of those I-plans are not connected with the community health needs assessments that happen in our hospitals. And what results in that? It's duplicative work. And then it often is, well, the resources don't align around combining the issues that are most important. So that was a great focus, and even some of the faculty in the Department of Population Science and Policy, Nicole Summers-Gubber, working around community health needs assessments, the Health System Science Division sort of thinking through different opportunities around alignment. But how can we create these structures on the level of the state where those things interconnect? We create the priorities that make sense for the community first and foremost. And that aligns both with healthcare delivery and local health departments. And then can we create the right kinds of resources and action with technical help and support? This is something that should happen in every community across the state. But as I mentioned, rural communities are often based on those connections to have those things happen easier, more efficiently, and bring people together to make that change. And then finally, just the idea of, well, we need a health in all policies approach. And so this is work that's been led by the University of Illinois at Chicago with IDPH. And it's based on legislation that was passed in 2019 called the Health in All Policies Act. And the Health in All Policies Act was an opportunity through legislation for all forms of government agencies to come together and come up with a plan that says, well, what does health mean to the Department of Transportation? What does health mean to the Department of Agriculture? How can we create the policies to address health inequities and think about striving for health equity across every agency in government, and think about the Illinois Department of Public Health and some of the other health and social service agencies not being the lead player in that, but being a supportive player around those issues in their domain to help bridge health in every single level of government. Now, as all things, that kind of got derailed a little bit during the COVID-19 pandemic. But we're back to submit our first report to the General Assembly and the governor's office at the end of this year around how a plan of health in all policies gets into motion. Again, part of this is that if you don't know about it, this is one opportunity, and we are going to sort of push this message because we can only create a health in all policies approach if we understand how those policies affect every single community across the state and how we can create the plans, the agency-wide initiatives, but also the legislative initiatives to make something like this work. And I lost this, so maybe that says it's time for me to be done anyway. But I think those three are just a small share of opportunities that we can have at IDPH to make a difference. These are big swings, right? And I think partly learning, sometimes to my own chagrin of, things in government take time, right? We're not the quickest of folks to kind of make change. But when we can make change, it creates a lasting and systematic effort around improving health inequities and striving for health equity. And so part of it, I can promise you that's my goal of working honestly to share your stories, to bridge the public health and healthcare divides, and to create a health in all policies approach. But I also want to know, and we want to know, well, why doesn't our program work the way that it should? And so that we can go back and we can amend that program, we can work with our legislative colleagues, our other agency colleagues, because we know that we have better practices, but we're all striving every day to achieve the best practice. And part of that requires all of your help and our ability to kind of make it happen. And although I, as the director of Illinois Department of Health, am passionate about all 102 counties, the last 7.5 years of my life have shown me the wonder, the innovation, the talent in all of our rural communities. And it's time to make those and elevate those in our statewide dialogue just as much and sometimes even more than those urban conversations. So thank you very much. And I know I have just a couple minutes, happy to take questions, and I'll be in the back too for a little bit and happy to kind of take questions then as well.
I applaud you for what you've presented and your vision. And Samir, it's the same vision that you talked to me about in, I think it was 2017, and you've stuck to it. So congratulations for that.
You guys are being easy on me. Well, oh, of course, Rex, please. No.
So what's the biggest challenge and barrier that you see?
I mean, I think part of the challenge just in government systems in general is because there is a different challenge every day of trying to be responsive to those challenges, right? Even in my very short time, day one, in a job like this, based on the last 2 years, knowing the challenges of the COVID-19 pandemic and understanding that maybe we're in a different time, we're sort of preparing now for a winter surge. But day one means that the governor is signing a disaster declaration around monkeypox virus. Fortunately, we've been able to have a robust, public health response, and the fact that this virus is different than the COVID-19 has allowed monkeypox virus not to be as big of an issue. But then all of a sudden, the governor of Texas buses asylum seekers to the city of Chicago. And how do we think about the social services and healthcare there? And talk about just feeling so excited to work around this team that's been organized by the governor, where it wasn't like, well, we're going to just let the social service agencies deal with this. From day one, we're thinking about a comprehensive government approach. And then, there is a international pathogen always potentially at risk, and how we can prepare our services in a midst of talking about challenges with pediatric bed capacity, with flu starting, with COVID-19 surge. And I think combined with that, all of that responsiveness with trying to think about these bigger, larger vision goals. And knowing that you have a short time to do that. And so how do you build the type of processes, and Rex, you've heard me talk about this so much, right? It's that the process, if you get the process right, that can live much longer than even doing the solution of the moment. And how do we create those processes? And how do we align in government and making it not just an IDPH process, but a process that creates the type of collaboration and connection and coordination that you need?
Just as a follow-up to that, then, do you have a sense of what needs to change in your agency, or how the rest of us can help advocate to keep your ability to focus on the crisis at hand and these bigger systemic issues that you highlighted?
Well, I think part of it, and all of you can help, I think, us advocate of, often your funding streams aren't flexible to align with the flexibility of the problems of the moment, right? We have a great deal of COVID-19 money from the federal government. Well, we couldn't use that COVID-19 money for monkeypox virus, right? And some of that, in some ways, is a health issue, but that goes to a different agency. And I know, Colleen, from your work, you know this too, right? It's not often sort of placed there. But also the communication, and I think one of the other things to respond to both of these comments is when we ask people what is public health, there are a lot of different answers to them. I used to think that was my population health kind of thing. Well, no one knows what population health is, but even more, public health, that's challenging. You know what happens when you go into a hospital and you get healthcare services. But what is public health? And we talk about some of the just ability to rise and create that pipeline, and we've done that around infectious disease. But all of the incredible leaders in our agencies that are worried about your environmental health, making sure that your water is clean, that we're taking care of, vector-borne illnesses. And then making sure even things like your milk is pasteurized, right? And those are layers of this sort of larger community story. And I think allowing us to share your stories, but also at a time where I think we have to get to a place where public health is not just COVID-19, and I think we'll all be better for it. Last one.
Hi, it's nice to see you again.
Nice to see you, Becky.
I was really interested in the slide you shared about birthing centers in the state. And I'm thinking through, how do we balance the kind of how spread out folks are in rural communities and the lower population with the reality of staffing shortages? And so coming from healthcare, when we're trying to figure out, how do we staff birthing units when there isn't as much volume and we need physicians, in these urban areas where there is volume, do you have any thoughts on, kind of the future of how do we address those competing kind of needs with the scarcity of resources in a way?
Yeah, and I think if any of us had that answer, right, that we would have fundamentally changed the scope of healthcare. Because right now, right, the payment infrastructure around that doesn't necessarily align with what you're talking about, right? And partly it's a little bit of a cliche, but I think, that idea of what does it mean to right size healthcare, what healthcare needs to happen in certain communities, but that also means the right ability to sort of pass that when you need more comprehensive care. I mean, we are every day dealing with this in terms of bypass around the limited pediatric ICU beds in the state, right? And it turns into, well, what do you go? What's the standard place that you should go? Who is the safety net place that happens, right? And we get a call and our EMS team sort of working through how to pinpoint that. And part of it, I think, a little bit to this point of linking public health and healthcare, how do we determine a financial model that doesn't allow this space to be necessarily competitive, right? And I think one of these things, and I'll applaud Memorial, because after the CMO meeting, I got some call from a leadership there to be like, well, we have made the decision here in town that there is a children's hospital in Springfield, and that children's hospital should be the place that thinks about, pediatric care. But in a time of crisis, what could we do with our adult providers that could open up the ability? Because we see people in 18, could we do that to 16? Is there guidance on how to do that even as early as 12, right? Because then that saves beds, right? And that collaborative nature, we need to support that more, right? It isn't often the standard of practice. And I think trying to do that and having the state help support those kinds of collaborations would be very beneficial. So I want to thank everybody again and want you to get to your next incredible speaker. So thank you. Yeah, thanks.
Theresa Eagleson has served as Director of the Department of Healthcare and Family Services since January 2019. Immediately prior to her appointment by Governor Pritzker, she was the Executive Director of the Office of Medicaid Innovation at the University of Illinois for 4 years. She has served in policy and administrative positions in state government since 1990, with a concentration in human services and healthcare. Her career included governor's budget and policy teams under 2 previous administrations and 15 years at the Department of Healthcare and Family Services. Director Eagleson is also the founding board member of the National Association of Medicaid Directors.
Hello, everyone. I chose not to walk back and forth because I'd probably pace all the way over there or something and break the rules. Great to be here this morning, especially with friends and colleagues like Director. I'm still calling you Dr. Vohra instead of Director Vohra. As someone also who has grown up downstate and has many family and friends, still about 2 hours southeast of here, really appreciate all of you for your work to help progress healthcare and public health for a part of the state that can sometimes seem overlooked, but I hope you're hearing from us today that I think we just have different ways to consider the needs in some areas, and maybe they don't get as much voice in the media and things, but that we're trying to listen and create policies to really change things in different areas across the state based on their different needs. As someone who also, as I said, grew up about 2.5 hours, or a little under 2 hours southeast of here and went to U of I can definitely attest to the fact that people think anybody south of I-80 is from, southern or rural Illinois. People thought I had an accent when I went to Champaign. And it was just like, what? I have what? So I want to talk to you today about building strength in these agencies that live well beyond us to serve people. And really kind of pick up, see if I can do both these things at the same time and move the slides. Really kind of pick up a little bit where Director Vohra left off about pushing us as state agencies to work together, especially as that relates to how we can do better across agencies and providers and community-based organizations, because you're the ones who see that, right? Better than we do. And if there's ever an opportunity, I believe it's in this administration to really make some progress there based on the people in the administration, our relationships together, and as Director Vohra described, all the way up to the governor, really pushing us to integrate, right, coordinate, and do better with government resources for everyone. At the Department of Healthcare and Family Services, we, right before the public health emergency started, about January of that year, we started revisioning, if you will, our agency's mission and approach. And you'll see the results here on this slide. We're really trying to reorient healthcare around our customers. We talk about our vision for improving lives, looking at social and structural determinants of health beyond traditional healthcare, empowering our customers to maximize their health and well-being, providing consistent, responsive service to our colleagues as well as our customers, and making equity the foundation of everything we do. It's not advancing. Oh, there we go. So for those of you who don't, public health, the Department of Public Health has so much breadth and depth across the whole state. HFS, Healthcare and Family Services, the acronym for the agency that I direct, not only administers the child support program, but also administers the Medicaid program. And Medicaid provides healthcare, for those of you who don't necessarily know, to more than 3.4 million Illinoisans, about a quarter of the state's population. So people don't really think about this, but we're the largest insurer in the state of Illinois, bigger than Blue Cross, bigger than Aetna. 1 in 4 Illinoisans depend on that care, which makes the ability through that purchasing power, like we can really drive some change. We can really push for differences. We can really, use that purchasing power, if you will, to drive results for our customers. And as I said, reorient the system around those customers. Medicaid is a state and federal partnership providing healthcare coverage for people with limited income. It's much broader today, thankfully, than it used to be. It used to be categorical. You used to miss a lot of people who weren't parents or who weren't seniors. But those healthcare delivery systems are organized now through mostly managed care organizations, and our networks include over 340,000 providers in about 114 different categories. There are also just an incredible number of local government and other partners beyond those healthcare providers that help in aspects of delivery and or management of the Medicaid program. Local health departments, almost all of them are, have intergovernmental agreements with us on aspects of working on the Medicaid program. Every school district in the state we have a relationship with. Many fire departments for emergency services and things like that. State and sometimes other universities. So just the breadth of that, we like to call it an enterprise, and tend to take that very systemic approach and look at how to change things. So I was asked to talk today about maternal and child health, and I love doing that, and I will do that. But I'm also going to preview that I'm going to go a little more broad and in depth on some of our other policies. But you saw some data from Director Vohra, and I'm going to talk a little bit about what we've done. But then I also want to put the challenge out there to hear from you about what we can still do. So I don't think I have to make the case, although I think I have a few slides here on demographics about maternal mortality and the unfortunate state of not only our rural communities, but also different populations in our state, especially Black women, and how those statistics look for them. So what have we done as an administration to try to improve that? And then what can we do going forward? It's a huge priority of Governor Pritzker and the leadership of this administration. Some of our recent maternal health initiatives have included full benefit coverage, meaning continuous eligibility for women 12 months postpartum. The Medicaid program used to only cover, like most insurance, 60 days postpartum for care, and now we go all the way to 12 months. We had done that even prior because, well, we were fortunate that, if you can say fortunate, the public health emergency basically had us not, and still has us to this day, and I'll close with a little bit about that, not doing redeterminations. So if you're eligible for Medicaid, you became eligible over the last 2+ years. We have not yet started doing monthly redeterminations. So your eligibility has continued unless you have moved out of state or reported some unique circumstance to us, but we have not done income redeterminations for over 2 years now. We added a second preventative postpartum visit just before the pandemic. We've expanded presumptive eligibility to get onto the program when you are pregnant. We have affirmed our support for and coverage of all reproductive health care services, including abortion, and updated our billing guidance and rates. And we've established maternal health as well as equity in health as pillars, two of the 5 pillars in our healthcare and family services quality strategy. The data, as you all know, finds serious health disparities for Black women, as I mentioned. The mortality ratio was highest for women living in rural counties as well as in certain neighborhoods in the city of Chicago. 71% of those pregnancy-related deaths occurred 60 to 364 days postpartum. So we really hope that that expansion to 12 months, as I said, can help us prevent some of that mortality. So that report back in, I believe it was 2015 or 16 when it came out, maybe it was a little later than that, recommended this change. The data supported the change, and so the General Assembly then passed this expanded coverage. HFS and this administration has also made the decision to do that for undocumented women who aren't necessarily eligible for the Medicaid program in its traditional sense. And we're using 100% state funds. We were using our CHIP program health expansion funds to do that, and now we're using all state funds because of some other changes that we've made for CHIP. But we have received approval to do that. So once the public health emergency is officially ended at the federal level, that coverage will continue. CMS, move on to another stage. We've also done additional coverage expansions beyond maternity. So we've done health benefits for immigrant seniors. That was effective back in 2020. And now we're adding other adults to that program. Children have always been covered regardless of citizenship status. And now we're expanding to adults of different ages. These programs so far do exclude long-term services and supports, but are very comprehensive otherwise and mirror the Medicaid program. Another big change that we've made that should be helpful to kids is that we've combined, if you will, the CHIP, Children's Health Insurance Program coverage, which took children up to 300% of poverty over the traditional Medicaid limit. We've combined CHIP and Medicaid. So some of that we did because we'd heard from not all of you, but some of you about the complexities of administering vaccines for children for two different populations. And we also removed premiums and copays for those children that were required by state law in the CHIP program. We got a law passed last year to combine all that, so there's no cost sharing for any child who's eligible now. It eliminates a 3-month waiting period if you're at a slightly higher income level and eligible for CHIP. Expands non-emergency transportation to those, again, slightly higher income level children's families, and allows care coordination through our managed care program. So looking ahead, what else are we planning around maternal and child health to give you a basis of how, where your comments and experience would be really valued? We're establishing a lot of new covered services through the program and provider types, including doulas, lactation consultants, community health workers, home visitors, and certified professional midwives. We have a state plan amendment in, which is how we change our contractual, if you will, relationship with our federal partners. A state plan amendment in to expand family planning benefits, a limited benefit program, to many more adults, effective December 1, coming right up here. And we're increasing prenatal and postpartum rates effective January 1, and building on significantly increased cross-agency collaboration with the Illinois Department of Public Health, as Dr. Vohra said. So this is how we've been organizing our work at Healthcare and Family Services. These 5 pillars, you'll see almost everybody on my team in medical programs talk about, I hope, when you hear them out about discussing changes, because we've been trying to drive all of our work into, to work toward the same goals in these 5 pillars. So you see them here: maternal and child health, adult and child behavioral health, equity, which is a very broad category, of course, and community-based services and supports, meaning making sure that people can live in the environment that's closest to their home setting. And this strategy really puts a strong focus on equity, prevention, and public health, paying for value and paying for outcomes rather than just volume and services. And we are proactively using analytics and data to drive our decisions around new programs, new rates, and really trying to address health disparities in all parts of the state as we do this. Each of the measurements, they're broken down here. I won't read them to you, but you can see some examples of both the maternal and child health pillar and the equity pillar coming up next here. But we're measuring all these things based on race, ethnicity, but also geography, area of the state. We're really looking at the disproportionately impacted areas of the state, several counties, which I'll show you a map later, where social vulnerability index is higher. So trying to look at and target our responses and see where we need to dig in, or our health plans need to dig in more, and try a different approach to affect these metrics in different parts of the state or for different populations. There are some of the examples of the equity pillar measurements. As I said, the managed care organizations are now reporting on all these we're collecting all these measurements off the data that they send us, but then they're also reporting to us things that we can't get off of claims data. So, and we are withholding money and only pay that back to them based on their compliance with some of these measurements. And some of the recent examples where our managed care organizations have jumped in with some of the additional flexibility that they have that a government agency doesn't necessarily have when we're paying directly is helping in the community of East St. Louis with some of the recent flooding. Tried to use another example of what Samir said. We tried to use some of the ARPA money, but couldn't quite do that. So got one of our managed care organizations to help with that flood assistance in East St. Louis. Also, this very localized approach to community engagement in these disproportionately impacted area zip codes. And our MCOs are also funding federally qualified health centers to push around social determinants of health metrics and performance. Sometimes I hear from people, and I may get some questions here today about why we use managed care organizations in the Medicaid program. But they're really our partners, and I wouldn't have wanted to go through the last couple of years of the pandemic without those partners and the ability of them to move faster than government can sometimes move. They did all kinds of things to reach our members, like mobile vaccine clinics, back to school, wellness events, connecting. You know, they passed out food boxes in a variety of communities, paid for childcare in some instances, energy assistance. There are all kinds of great stories. So while I know that there are still complaints and we have things to work on, I'm very proud of the progress that HFS has made with these partners in managing the program and expanding access in a lot of areas. So, access to care, huge issue for us. We continue to innovate and explore service delivery opportunities to assure access to healthcare in all parts of the state, but including rural Illinois. Telehealth parity, we were an early adopter. We expanded our emergency rules to permanent even prior to the bill that passed last year. We are currently working to study the effects and look at future policy tweaks we might need to make. So looking forward to input there. We implemented over $550 million spending plan with funds from the American Rescue Plan Act to give to share money with providers throughout the state and strengthen everything from hospitals to nursing homes to home community-based service providers. We just increased Medicare and service car base rates. So that's especially important. Transportation is a huge issue, as many of you know, in rural Illinois. And while there wasn't a specific focus on rural or downstate Illinois in our recent dental rate increase that's being put into place, we did increase reimbursement rates. We tried to target them to more the preventive aspects of dental care. And I'll go out on a limb and say that we need to do more. And we have been talking about and thinking about, and again, love to hear input about how we do more with our rates to target improvements and expansions of services in places who have more need, right? Whether that's an underserved area in the city of Chicago or, you know, the southern 7 counties of Illinois. How do we use the Medicaid program to make sure that services get to the people who need them everywhere across our state? That might mean we need to pay more for somebody to go to a certain area of the state. So I'm kind of putting that out there to get us thinking differently as opposed to just paying equal for everything. Another thing that we had done, I missed on the list there early in our administration, was do exactly that, pay differently. We started paying dispensing fees much higher for critical access pharmacies. So pharmacies in underserved areas that aren't connected to hospitals and don't have ownership or control in more than 10, I believe it is, other, pharmacies, so not the big chains, right? Really brick and mortar, trying to keep that local access in a lot of rural communities. And our healthcare transformation collaboratives. Did I skip a slide? Let's see. Yeah, I must have. One that I'm particularly proud of. Sorry. I think I have a finger that's going faster than my mouth here. Or my brain maybe. One I'm particularly proud of is that Healthcare and Family Services led a 2-year data-driven reform process resulting in some first in the nation reforms for nursing home care. We worked in partnership with our colleagues at the Department of Public Health, sharing a lot of data. And this is one that oftentimes in rural areas, there are not a lot of options for an even more elderly, sometimes community, right? And so one of the big things that we did was we equalized wages. Previously, our nursing home rate methodology had like an inflation factor for wages in more metropolitan areas of the state. And the staffing shortages and staffing crisis affects the entire state, maybe affects rural Illinois even more. So we took that, we basically raised all boats. We took everybody to the top wage in that. So rural and downstate Illinois nursing homes got an even larger bump than the overall bump that we gave in this reform package. And the biggest piece of this reform package was to directly tie increased funds to increased staffing. In nursing homes, staffing is the #1 predictor of quality. It's probably true in a lot of healthcare settings. And CNAs are the backbone, right, of nursing homes. And so we literally tied, starting at $9 a day, going all the way up to $38 a day, for every increment on the federal staffing scale, starting at 70% of what the feds recommend, going all the way up to $38 at a little over 100% of what the feds recommend. We've now linked $1 in every $6 of what we pay directly to those staffing levels. Huge change, right? Paying for what we want to see for our customers. And elevating the CNA workforce. We also created a CNA wage scale as part of that, which maybe we want to look at taking to other similar job titles, right, in other health provider areas. But it basically ties a $1.50 rate increase at the first year of a CNA's tenure, $1 after that for every year up to, I can't remember exactly where we stopped at that, but really creating that incentive for people to stick with the profession, right? And to stay in the profession. So this is something that we're really proud of and really was our first big public foray into how do we really get into the data, look at what will impact care for people, and recommend changes. This was a huge one to get through the Illinois General Assembly. Rates for a lot of our healthcare providers are set in statute in Illinois, so we had to convince a whole lot of people why this was a good idea. And another big change since the inception of this administration is our healthcare transformation collaboratives. And this is in partnership with the Department of Public Health, the Department of Human Services. But really, I think of healthcare transformation collaboratives as kind of venture capital, if you will, for more providers who are more traditionally dependent on Medicaid or federal funds, to really give them create that opportunity for them to work with community partners and drive system change for our customers. We made a decision very early on when we were pushing to create this pool of money to put out in the form of these collaborative awards, if you will. We made a decision very early on that we wanted this to be varied in different areas of the state. Communities know best what they need and who's best to work on that, right? So we made it very community driven, based on the needs and strengths both in different communities. And these are the areas of the state. There are several awards in and around the Chicagoland area, but there are also several awards in downstate and more rural Illinois. You can see here on this map, the red dots are counties that have a social vulnerability index. It's a CDC measurement, probably most of you are pretty familiar with, score greater than the Illinois state average. So we were really trying to target areas of the state that have that increased vulnerability, if you will, and have done that. I will talk about 2 of these projects and really trying to create awareness here. So you might get involved if you're around some of these projects, or look at joining one for a future round. So Egyptian Health Department has a project in Southern Illinois. They just broke ground. Our Medicaid administrator, Kelly Cunningham, went down there. They are really looking to join primary and behavioral health care, invest in workforce and wellness. They're actually constructing a building that brings a lot of local providers together in that area. It's called iHub. And there's more information on all of these on our website, as well as the program as a whole. And we just approved a new project in Vermilion County over in the eastern part of the state recently. And they are seeking to improve chronic care outcomes and increase access to preventive treatment and specialty care services. Carl Foundation is helping with that project, helping lead that project, but there are about 15 other providers involved in that project. So really excited about that. There's also a telehealth-driven project in the western part of the state led by OSF. So looking forward to what some of this new innovative funding can do in communities. And I'll close with talking about maintaining eligibility for those 3.4 million people that depend on Medicaid for their health care when the public health emergency eventually lapses. We can't pay for services for people who aren't on the program. So it's really important. As I was saying before, the public health emergency has given us the ability not to do redeterminations for a period of time, but that's also left us out of contact with a lot of our members and customers. And so, we have potentially bad contact information. We don't want somebody who's eligible to fall off the program when these redeterminations start again. So we've really been trying to educate everywhere about how to report that information to us to keep people on the program. The federal government's continued that public health emergency. They've promised us 60 days notice prior to it ending, when the public health emergency is about more than just how the virus is spreading and things like that. As many of you know, that brings a lot of funding opportunities to the state in different ways. It allows us to waive a lot of rules that would otherwise be in place. So they've promised us 60 days notice at least. The current public health emergency goes through January 11th. So we would expect notice coming up here in a few weeks if it's not going to go beyond that. So what are we doing to make sure that we connect with our customers and focus on right now in phase 1, them updating their information. And then once we know of a particular end date, our approach will change a little bit. But there's a lot of information available online. We have a toolkit as you're working with customers in your communities. that we hope you'll take a look at. It includes all kinds of things from sample emails to flyers, and it's really right now, update your address, we have a very simple one page, not even one page, it's like 8 or 9 line form online to have people put in their contact information, best contact information. So we're asking you to help us get that message out to keep as many people covered as possible. And with that, see how am I doing on time? I talk pretty fast, apologies, but that'll leave more time for questions. I want to thank Dr. Kruse, Dr. Vohra, and every single one of you who are working to bring quality health care to people all across our great state of Illinois, especially to those who depend on Medicaid for their health care. This administration, up and down, believes that access to quality health care should be a right for everyone and not a privilege. And we couldn't do it without each and every one of you and your teams, and appreciate your contribution to that all across the state. Thank you very much. Plenty of time for questions, discussion. I'm sorry, I can't see very well across the room and don't know names, but I see your hand up in pink.
Hi, thank you so much for that presentation. I really appreciated it. Lots of new innovations and things that I was not even aware of. I'm a general pediatrician here at SIU. And my question is, how can we help engage with some of the providers that are not willing to provide services to patients who receive Medicaid? So if we're talking about health disparities and how to remove some of those, my clinical perspective is that many of our community partners are unwilling or unable to provide services to patients who have Medicaid. And then that kind of shifts the burden to academic centers or other places that are willing to do so. And I just wondered from a larger perspective if you would comment on that.
I mean, several things. The networks, unfortunately, they've both expanded and contracted in different ways with our managed care partners, right? We have thousands more providers when you look across all of the managed care, all 5 managed care companies in Medicaid. We have a lot more providers enrolled, but yet then we have these contractual disputes and other disputes that do shift that burden. I mean, I think education is one thing. People still talk about Medicaid being low pay, slow pay. Everybody gets paid in 30 days. Almost without exception. We monitor that. It's a federal requirement. I mean, I was the Medicaid director for the state for 8 years prior to a little break and came back as director, and we have increased physician and a multitude of other rates, but increased physician rates quite a lot. We used to be a horrible partner as far as paying. I'll say that out loud. And now we've really pushed, right? Part of the beauty that the MCOs bring is that they're responsible to pay people even when we don't pay them. So I think education is first off, but also, let us know how we can help. Sometimes a phone call from somebody at, my department or the Department of Public Health or something to say, could you take another look at this? And can we really talk about the impact it's having in your community? I mean, I've done that. I can't tell you how many times over my career. So I think, hearing about those things that we may not know about in specific communities. I know some of what you're referencing here locally and have tried to influence some of that and have been unsuccessful in some ways. But I think just communication and education and open to hearing other ideas.
Director Eagleson, we have a chat question.
A chat question?
Yes.
I
We have
forgot that
several
we have a
coming in.
broader audience that is in the room. It's great.
The question is from Tommy Thompson. You and others have mentioned discussions with rural communities as they know what they best need. What means are you looking into to have those discussions? For example, surveys or panels in those communities?
So we engaged a partner, the University of Illinois at Chicago Institute for Healthcare Delivery Design, when we started our healthcare transformation collaboratives. And they did exactly some of that. They went out into different communities. I showed you those communities with the red dots, social vulnerability indices higher than the statewide average. And they are still working across different areas of Illinois, but having community panels with providers and really customers. We're trying a lot more to talk to our customers. We have a Medicaid advisory committee that meets every quarter, and we have several subcommittees of that are public meetings. Anybody's welcome to attend. You can sign up to give public comment. If you're interested in serving on any of those committees, you can apply to do that on our website, because that's another way to bring voice to a variety of communities. And also, one of the, as Dr. Vohra was saying, one of the good things maybe about the pandemic is those meetings used to be in person in Springfield and Chicago. There we had 80 people in each room, and we were on video conference between two rooms. Since March of 2021, we've been doing those meetings online, virtually, right? So it's much easier to get to those meetings, to listen in, to offer your comments. And I'm happy to hear from you in communities about what you've learned. Every hospital does, community health assessments across the state. Communities do other kinds of health planning things. So I don't know that we need to necessarily redo that, right, from a state level, but love to hear from you as to what your specific needs are in your communities.
And another chat question. Medicaid is already the largest line item in the state budget. What dollar amount in additional appropriations for expanded women and child services and increased labor costs has been already approved by the legislature? And where is the funding coming from after COVID funds expire?
That's a complicated question. There were about 6 parts. So yes, it is the largest budget, but I am also proud to say that we've done a really good job in being creative and trying to draw down additional federal funding even before the pandemic. Yes, the pandemic gives us a 6% bump in our Medicaid match, which is, on average 51-ish%. But we implemented a managed care provider tax to fund the nursing home reforms that I was talking about, all but about $100 million of that. And when I say $100 million, I know that sounds like a lot of money. When you're talking about $36 billion budget, which is what ours is, all funds, it's something that we can manage. So where's the money going to come from? There's a lot of different places and new revenue sources that have been pushed. Doesn't mean we're not going to need more, and to be creative about those types of things. But definitely already thinking about that and have no intention of scaling back services, which is probably a big part underlying that question. Yes, right there in the, oh.
I applaud the efforts of HFS in supporting the full scope of reproductive care, and have been thinking a lot about the Dobbs decision in the surrounding states, and wondered, and particularly, there's a lot of rural folks in the surrounding states as well, and wondered if HFS support has any role in access to care for those states that have outlawed abortion.
Outside of the state borders? Yeah, it's a tough question. We absolutely want to bring access, the same level of access that we have in Illinois everywhere, but we're also kind of a little leery about taking on the financial responsibility. our federal partners have talked about a funding opportunity, but they've limited it to more Hyde Amendment abortions. If you're familiar with, just rape, incest, life, most abortions are more on the health side of the equation, and that's so. We've been talking with other big states and our federal partners a little bit about what we can do. We're very interested in how we can be helpful without, like I said, taking on all the responsibility that might be one of our neighboring states. But Governor, giant supporter of reproductive rights. So am I personally. So still, and so is the entire administration, looking at how we can be helpful, but proceeding with a little bit of caution, but still. And I have not heard of cases where any of the providers in Illinois have refused people to date. I know our providers have been very open in the conversations that we've had with them, and there's a team at Public Health as well as a team at my agency that have been looking at this together.
And we have a final chat question. How will the information be distributed to doulas so they can understand the process of how to get reimbursed?
We have a provider notice system, if you will. We're probably going to create a new category in that. We also realize that this is a really new provider type with a lot of people who haven't, been as familiar with the Medicaid program. So we're undertaking some efforts in partnership with the University of Illinois and SIU to help do some education around billing. There's a new, it's barely off the ground, so I hate to advertise too early, but we have a Medicaid Technical Assistance Center that's kind of charged with doing things like that, helping us bring up newer provider types who aren't as used to billing Medicaid or healthcare in general. So we'll probably use that avenue as well. So I would say stay tuned, and if you have ideas or forums or associations or that we could, once some of these policies are a little more formulated, that we could get out and talk to, please don't be shy. hfs.director@illinois.gov. HFS, the initials of the agency, .director@illinois.gov. And that comes to actually my email that's monitored by a team because it's pretty hefty volume, as you might imagine, and especially when I do that. But we'll try to get you the right place. Other questions? Another one.
I just wondered regarding the expansion of postpartum care for 12 months. Are there other states that are following Illinois' lead?
There are. We were the first, but there are probably almost going on 10 states now who have either gotten 1115 waivers or now are submitting state plans to do that. Yeah, several states, but not all yet. So, yeah. Thank you all so much.
All right, it is 10:05, so we're going to take a 15-minute break. We'll start promptly at 10:20, and we now have soda and tea through the double doors over here. So see ya in 15 minutes.